Hello. I'd like to start by thanking the LeaRRn leadership for the opportunity to speak with you today about a body of work that is dear to my heart. Since its inception 20 years ago, my research program has been strongly informed through formal and informal engagement with various stakeholders and health systems. I'm fully convinced that this engagement has strengthened and enriched the research that we've conducted together. It's a privilege to share some of the strategies that we've used to collaborate with rehabilitation recipients, providers, and health systems, as well as to share some of the findings we have generated to inform the design of future studies. The LeaRRn leadership has already invited more than one elegant talk on the importance of engaging stakeholders in learning health systems research. Therefore, I will focus my remarks on the rationale for creating strong partnerships with stakeholders and health systems when designing and conducting pragmatic trials in clinical rehabilitation settings. I will also share the methods that we are currently using as we seek to understand organization and provider contexts and readiness to inform the design of a large national pragmatic trial in inpatient rehabilitation. Here are the main points. Stakeholders from various perspectives and health system partners are essential to conducting meaningful and successful trials in pragmatic settings. In addition, a prospective examination of stakeholder and health system perspectives is useful for elaborating variations among facility and provider contexts, as well as their readiness, informing the selection of implementation strategies, and saving time and money to prospectively plan pragmatic trials that have a high likelihood of success. Years ago, one of my mentors taught me that explanatory trials are like studying a lion in the zoo. And pragmatic trials are like studying the lion in his natural habitat. Explanatory trial design is useful for studies examining the potential mechanism of change affected by a specific intervention on a specific target outcome. Depending on the research question, well-designed explanatory trials seek to control for potential sources of variation that may confound the explanatory power of the experiment. These trials often use carefully selected participants to receive intervention through highly trained staff under well-controlled conditions. In contrast, pragmatic trials examine the potential effectiveness and implementation of an intervention in real-world settings. Depending on the research question, well-designed pragmatic trials allow for potential sources of variation to characterize the robustness of the intervention effect and implementation among heterogeneous participants, staff, and organizations. Thus, pragmatic trials require an understanding of the nature of variability in who are receiving the intervention, who will be delivering the intervention, and the delivery setting and conditions of the intervention. When conducting trials in pragmatic clinical settings, we must acknowledge that our trials are subject to high variation in individual characteristics with respect to the patients receiving services, but also the providers delivering services. There's also high variation in internal factors such as organizational values, culture, and structure. These settings are also subject to high variation in external factors such as community needs, resources, and payer policies. These variations in culture and structure, as well as variations in service access, quality, and consistency, can strongly influence pragmatic trial success. If we seek to design studies to be conducted in pragmatic clinical settings, we must engage stakeholders and health systems to garner the breadth of expertise needed to understand and embrace the variation and factors embedded in these settings. My research program has comprised a range of explanatory and pragmatic trials, with most of these studies conducted in the pragmatic setting of inpatient rehabilitation. Our research questions have focused on how we might optimize interventions in inpatient rehabilitation to set the trajectory for independence after an acute injury or illness. Given the difficulty of studying inpatient rehabilitation in controlled conditions, we embraced stakeholder and health system engagement from the start to inform the design and the conduct of trials in this clinical environment. Briefly, our early engagement of stakeholders told us that health systems providers, patients, and their families were all concerned about inpatient rehabilitation outcomes, as indicated by independence with daily activities at discharge and over the long term. However, our studies showed that ineffective patient engagement and learning strategies, often used by rehabilitation providers during inpatient rehabilitation settings, can contribute to the acquisition of dependence and long-term disability. Through a series of studies, we set out to identify an intervention that promoted active engagement in learning and contributed to significantly better inpatient rehabilitation outcomes. With input from rehabilitation providers and patients receiving inpatient rehabilitation, we learned that strategy training showed the greatest promise. Strategy training differs from traditional rehabilitation approaches in that it teaches patients to use a global strategy that helps them select meaningful daily activities to practice during rehabilitation, try the activities with support from a therapist, assess and reflect on their performance, and develop their own strategies to improve their performance through iterative practice. Therapists use guided problem solving in concert with the global strategy to elicit the patient's engagement and active learning in a safe and structured format. Strategy training can be applied by any discipline in any rehabilitation setting. Our studies have focused on the delivery by occupational therapists, physical therapists, and speech-language pathologists during inpatient rehabilitation. To illustrate strategy training, it's useful to see it in action. We'll illustrate how a client and a therapist use the approach to address a routine task during inpatient rehabilitation, that is, oral care using a water pick. While you're getting a sense of the intervention, I would encourage you to take a note of the impact of the complex clinical rehabilitation setting during these videos.
All right.
Okay.
I'm ready when you are.
I'll get up. Okay. Now you know I'm already takes 2 hands for this, so I kind of have to.
You take your time and
get over it. I'll put it on my mouth, and what you do is press this button here.
Do you think you can do that?
Yeah.
Too?
I don't know. I only have one hand. If I hold this is the bad hand. If I use that way. I'd have to cross over. It's going to spray all over.
Wonder if this outlet's working,
I think there's that little plug underneath your throwing thing that's press it in, you said?
Yeah.
One of the values of using this video is to show you what happens in real life. This happens to be real life in the clinical inpatient rehabilitation setting, but could very easily have been a real life scenario that this client would have encountered upon home. Another reason to do studies in pragmatic settings. This video illustrates what happens after that session, the same day, as they assess and reflect on that performance.
Did we do the plan that we came up with?
That's right.
Okay. We tried to do the plan. Okay, and what worked well and what didn't work well about the plan? What happened?
I forgot. I just thought compatible.
Okay.
Or the table.
Sure. Did the table work well, do you think?
I think it would probably bring that up and it would be.
Okay.
Yeah.
All right, so we'll need a, if the sink is small like that one, we'll need a table. Okay,
at
so.
least on the same height, I would imagine. Table
Okay.
or shelf.
Table or shelf to hold the water pick then?
Or a sink if it's, the sink is
If it's,
big enough.
Sure, larger like
yeah,
this.
That would be ideal.
okay. All right. Now we have to decide what the next step is.
We're going to ask somebody
Okay.
have plug for the outside of license.
Okay.
And then maybe it'll direct us to look for at least, I think the ones that are normally must be special ones.
Okay. So we're gonna ask. Do you have any ideas?
I think you could ask the nurse.
Okay.
The head nurse.
Okay.
She should be able to tell us.
Sure. And are you gonna do that, or am I gonna do that?
You do that.
Me?
I think
Okay.
you're free.
Sure, I will do it. I just want to check with you what the plan was.
I just know.
So as you can see from this video, the therapist is using a guided problem solving to help the client think through how she might encounter or address performance in her daily life. And this video illustrates what happens the next day after the revision of the plan.
I think I can take the whole reservoir off.
Okay.
We'll just go halfway because I think it's like 2 minutes overall.
Oh, that's no, I'm in no rush at all, so
Okay.
you take your time. Don't rush on account of me.
Well, first time we'll do it this way, okay?
Okay.
So as you can see, using real-world problems and pragmatic settings can be a very useful training tool, and studying it within the clinical rehabilitation environment allows us to learn a lot about how that intervention might perform, as well as how it might be implemented. Our design and application of strategy training in this setting has been heavily shaped with significant input from providers and patients engaged in the intervention. For example, we needed to be able to deliver the intervention within a few days of admission to inpatient rehabilitation in order to get enough sessions of the intervention in before discharge, meaning that we had to simplify the approach. We also needed to be able to deliver the intervention within the usual boundaries of time, available resources, and length of stay within the setting. You will note that our initial sessions required 42 minutes on average, but we have since refined the protocol such that they require 25 to 30 minutes in 1 to 2 sessions per day to achieve the same intervention effect. This allows time during inpatient rehabilitation for other interventions as needed. We have demonstrated that we can administer strategy training in the inpatient rehabilitation unit using available supplies. Furthermore, we demonstrated that both patients and therapists have high satisfaction with strategy training, and so far we've observed no adverse events. Furthermore, we've not needed a longer length of stay to achieve the clinical effect we are seeking. However, our initial training package for the therapist was time-consuming. We had to go back to the drawing board and sort out a simpler, less time-consuming training package while maintaining the same level of intervention fidelity. We have since met this need. We established that strategy training differs from traditional interventions typically used in inpatient rehabilitation, particularly with its distinct focus on guided problem solving. As you can see on the slide, the leftmost bar is strategy training, and the red area indicates the proportion of the session that's devoted to guided problem solving. The second and third column illustrates the amount of guided problem solving that we observed in usual occupational therapy and physical therapy sessions, less than 5%. We've since repeated this finding in several health systems. On the right side of the slide, you can see that the amount of guided problem solving varies by client, by activity, and by session, but on the whole is more prevalent than it is in usual care, occupational therapy, and physical therapy sessions. Our studies have demonstrated that strategy training is feasible in inpatient rehabilitation. Furthermore, our explanatory trials also demonstrate that strategy training promotes more active engagement and learning in rehabilitation sessions, as well as better motivation and self-awareness compared to traditional intervention approaches in inpatient rehabilitation. Most importantly, strategy training is more efficacious for reducing disability compared to enhanced usual care. In these studies, strategy training, or the comparison intervention, was administered in 1 session per day as an adjunct to usual care in the inpatient rehabilitation setting. We've also compared strategy training to other approaches, including a direct skill training approach, which is an enhanced version of the prevailing approach used in traditional inpatient rehabilitation settings. In short, strategy training is associated with significantly greater improvements 3, 6, and 12 months after discharge. The difference in mean change scores over the 12-month period resulted in significantly in clinically meaningful effects. Given the design of the study, the medium effect size of difference can be attributed to the guided problem-solving ingredient of the intervention. We have also characterized who does and who does not benefit from strategy training. For example, strategy training shows promise for maintaining low levels of apathy and improving awareness of deficits, as well as addressing the needs of people with aphasia. But it's not promising for people with dementia or people with certain ventral medial lesions to the brain. And we have characterized variation in intervention response using a variety of outcomes. For example, we notice a difference in intervention response as measured by disability scores based on whether patients receive 7 or more sessions versus those who receive less than 7 sessions. More recently, we demonstrated in a single pilot observational study that strategy training is feasibly implemented by a clinical team comprising an occupational therapist, a physical therapist, and a speech-language pathologist in one inpatient rehabilitation facility, and that doing so resulted in significantly greater reductions in disability compared to matched cases who received usual care from the same team. The next steps are to design larger scale pragmatic trials that assess the effectiveness and implementation of strategy training in inpatient rehabilitation across multiple facilities. Karan and colleagues suggested that health scientists improve the rigor and efficiency of study designs by embracing simultaneous testing of clinical effectiveness and implementation and highlighting one of 3 approaches. Hybrid type 1 studies test clinical effectiveness while gathering information on implementation. Hybrid type 2 studies test both clinical effectiveness and implementation strategy effectiveness. And hybrid type 3 studies test implementation effectiveness while gathering information on clinical effects. We are aiming for a hybrid type 1 study where we will test the effectiveness of strategy training in inpatient rehabilitation while exploring the feasibility of implementation strategies within and across facilities nationwide. From our previous studies, we've learned quite a bit about information to inform the design of the effectiveness arm of our study. However, we've lacked information to inform the design of the implementation arm of our study. Specifically, we are now directing our efforts to better understand variations among providers and facilities that may influence both effectiveness and implementation of strategy training on a larger scale. Once more, this is where stakeholders and health systems become important. To inform our next steps, we identified a large national health system partner and a breadth of stakeholders to co-design and oversee the planning for our pragmatic trials. We intentionally sought stakeholders to represent the perspectives of the health system, the providers, and the patients in inpatient rehabilitation. Unfortunately, I do not currently have pictures of the full team, but I will acknowledge each person by name and role as I think it highlights the strength of our approach. First, we built a relationship with Encompass Health, a national rehabilitation provider who funded the implementation pilot study I just mentioned and demonstrates a strong investment in studying and implementing strategy training in their inpatient rehabilitation facilities across the nation. We partnered with Encompass Health administrators to serve as co-investigators and members of the Stakeholder Advisory Board. Cheryl Miller is a Vice President of Therapy Operations, and Scott Blakely, the Regional Director of Therapy Operations. They are joined by Rebecca Blumler, Greg Wojcik, and Amanda Yost, who are full-time inpatient rehabilitation providers at Encompass Health. We also partnered with Tina Harris and Barbara Wright. Both are persons who have previously sustained a stroke and currently serve as patient advocates. They serve as co-investigators and members of the Stakeholder Advisory Board. And we partnered with 2 clinical scientists, Angela Benfield, a content expert in professional reasoning at the University of Texas, San Antonio, and Jennifer Stevens-Lapsley, at the University of Colorado Anschutz, who has quite a bit of experience in conducting pragmatic trials in clinical rehabilitation settings. Alex Harper and Min-Mei Shi are occupational therapy scientists who provided considerable input into the design and conduct of the study. I would also like to acknowledge the contributions of Leanne Cheng, an OTD student, and Stephen Lau, a postdoctoral trainee, who assisted with data management and analysis. By design, this team is diverse in stakeholder perspectives, as well as in social identities such as age, race, and ethnicity, ensuring that we consider a breadth of lived experiences when designing and conducting our studies. Under the guidance of this full team, we designed a study to characterize variations in context and readiness among providers and facilities throughout the nation. As I mentioned previously, Encompass Health is a large national for-profit rehabilitation company with over 150 rehabilitation facilities in the continental United States and in Puerto Rico. For AIM-1, we characterized variations in facilities, providers, and patients among the 139 inpatient rehabilitation facilities that were operational at that time. We then selected 30 heterogeneously representative inpatient rehabilitation facilities using a prioritization structure recommended by our stakeholder advisory group. For AIM-2, we did a deeper dive into the 30 selected facilities to examine facility and provider readiness for strategy training implementation and to explore perspectives on barriers and facilitators to strategy training implementation. We are now using the process of data analysis and integration to inform our selection of implementation strategies for our next pragmatic trial. To guide our data collection for this study, we use the Consolidated Framework for Implementation Research, or the CFIR. The CFIR provides the taxonomy of factors within the outer and inner setting of an organization, as well as the innovation or intervention characteristics, individual characteristics, and process factors that may influence implementation. Let's start with AIM-1. AIM-1 sought to characterize variations in context and to select heterogeneously representative inpatient rehabilitation facilities. We gathered data on the outer and inner setting, as well as individual characteristics of providers and patients at each facility. I will specify these individual characteristics on the next slide. To gather data on facility characteristics, individual characteristics, we administered an electronic survey. Facility characteristics included the geographic region, size, and service area, as well as information on the operational structure, accreditation, admissions data, and staffing levels. For providers, we gathered information on the highest level of education, specialty certifications, and years of experience. For patients, we gathered aggregated information on age, sex, percent who needed or wanted an interpreter, race, ethnicity, insurance, health literacy, rehabilitation diagnosis, and admission disability scores. These were aggregated over the last 12 months prior to the study. Items in bold were prioritized when selecting the 30 representative facilities. For these data, we augmented selected indices from the Centers for Medicare and Medicaid Services Care Compare website. This slide depicts the 139 inpatient rehabilitation facilities from which we collected data. As you can see, Encompass Health facilities are more densely concentrated in the East and Midwest and more sparsely concentrated in the West. We took this into account when selecting facilities for our study. We sought to stretch the geographic representation as much as possible and to ensure close to equal distribution of small, medium, and large facilities. To inform this selection, we examined average daily census as a proxy indicator of facility size. This slide depicts the 139 facilities split out by geographic region as defined by Encompass Health. On the x-axis, you can see the average daily census. On the y-axis, you can see the number of facilities within each region. As you can see, there's quite a bit of variation in facility size within and across regions. This slide depicts the distribution of race among patients served in the previous year by region. We also examined these distributions by facility so that we could identify facilities with higher proportions of patients who identified with historically marginalized race and ethnic groups. The slide depicts the distribution of facilities based on median household income of patients served in the last year by region. We also examined this by facility so we could identify facilities who served high proportions of patients with median household income below the national median. As I've already indicated, our stakeholder advisory group is comprised of peer advocates, providers, regional directors, VP of Therapy Operations, and external consultants. Using data from AIM-1, the stakeholder advisory group used a nominal group technique to select the 30 heterogeneously represented facilities for AIM-2. Our stakeholder advisory group prioritized facility selection by suggesting that we ensure equal distribution, or as equal as possible, by geographic region, facility size, and the clientele. However, they suggested that we oversample facilities with high proportions of patients served in the previous year who identify with historically marginalized race and ethnic groups, as well as facilities with a high proportion of patients with household income below the national median, and facilities with a high proportion of patients under the Medicaid insurance. Here you can see the 30 facilities that we selected for AIM-2 based on the prioritized characteristics. As you can see, we attempted to enroll as many of the Western sites as possible to give us some geographic spread. And we also included 2 facilities within Puerto Rico. This slide provides a summary of the characteristics for those 30 facilities based on the prioritized criteria. You will note a fair distribution based on facility size, as well as our attempt to oversample facilities with higher proportions of patients who identify with underrepresented race and ethnic groups, and higher proportions of patients with low household income and Medicaid insurance. Compared with U.S. Census data collected in 2020, the distributions in the selected facilities are similar to the national population, except for low proportions of patients who identified as Hispanic, Latin, or Asian, and low proportions of patients who had Medicaid insurance. Compared to data from the National MedPAC report on inpatient rehabilitation facilities, selected facilities are significantly more likely to be freestanding and to admit patients with neurological conditions, amputations, arthritis, and pain. Selected facilities are less likely to admit patients with fracture, joint replacement, cardiac, or spinal cord injury diagnoses. The selected facilities were comparable with average CMS care compare data reported by inpatient rehabilitation facilities throughout the nation. Now let's turn our attention to AIM-2. In this AIM, we sought to examine facility and provider readiness among the selected facilities. We gathered perspectives on the outer and inner setting, the innovation or intervention characteristics, and individual characteristics from facility directors of therapy operations and providers within the selected facilities. In this study, we did not assess the CFR process domain as we have not yet implemented strategy training in any of these facilities. We administered a standardized questionnaire called the Organizational Readiness for Change Assessment to 1 director of therapy operations and 6 providers in each facility. We also administered 3 additional standardized questionnaires to providers: the inner setting questionnaire, the evidence-informed professional thinking measure, and the evidence-based practice attitude scale. We administered focus groups to directors and providers separately using a structured interview guide. The interviews explored previous experience with implementing new processes, as well as perceived barriers and facilitators to implementing strategy training within their facilities. The left flow diagram shows that we're able to recruit 30 directors and obtain complete direct data from 29 of the 30 directors, or 97%. The right flow diagram shows that we're able to recruit 173 of 180 providers and obtain complete data from 152 of these providers, or 88%. These data point to the importance of strong partnerships with health system administrators as stakeholders in our research. This slide shows the mean scores from the Organizational Readiness for Change questionnaire, split out by directors and providers. The measure assesses perspectives on the evidence for strategy training, as well as the context or the setting's readiness for strategy training. As you can see, on average, directors rated organizational readiness a bit higher with less variation than providers. We are currently examining facility-level responses to inform how we might stratify implementation strategies based on facility characteristics. Here we contrast 3 facilities of different size to depict the variation in provider perspectives on facility culture, implementation climate, learning climate, leadership engagement, and available resources for strategy training implementation. These facility-level differences are interesting and useful in identifying potential implementation strategies. While we are still analyzing the facility-level data, our current analyses suggest that we may need to stratify implementation strategies based on facility size. Our current steps are focused on combining the questionnaire data with themes identified from the structured interviews. We will represent these data using a joint display. On the slide, you can see the current joint display based on data analysis completed to date. Because this is a new tool, I'll take some time to explain its use. In the first column, you can see the CFR domains, which we use to organize our data collection and analyses. In the first row, you can see that we are comparing quantitative data from the standardized questionnaires and qualitative themes that we gleaned from the focus group interviews for the 30 facilities. Our intent is to combine this information to generate inferences that will allow us to make sense of what we learned from both data sources. These inferences can reveal a concordance of information from both sources, an expansion of information gleaned through qualitative information or sources, or a discordance of information from the 2 sources. These inferences inform the discussion we will have with our stakeholder advisory group once all data analyses are complete. For example, let's consider what we've learned about the outer setting. Currently, we're comparing the quantitative data gleaned from the CMS Care Compare website with qualitative themes that emerge from focus groups. In short, we learned that relative to the outer setting, in general, the selected facilities are of comparable quality to the national averages as reported on the CMS Care Compare website. Furthermore, directors and providers feel that strategy training is consistent with payer policies and organizational support. However, there were some variations among facilities. With respect to the inner setting, directors and providers perceive an overall favorable readiness in their organization, with directors rating readiness and implementation climate slightly more favorably than providers. Both directors and providers report prior experience with implementing new practices, and directors are consistently reporting a higher level of confidence with implementation. Providers' confidence is mixed, and it appears to vary based on facility size. This leads us to conclude that we should leverage successful systems and strategies that have been used in previous implementation of new practices within the health system, as well as consider stratifying our strategies based on facility size. With respect to the innovation characteristics, in this case, the response to implementation of strategy training in particular, directors and providers report that on both the questionnaires and in the focus group interviews, they feel that the philosophy of strategy training is consistent with their current approach to treatment, and they favor the strong evidence base and the well-tested and simple packaging of the intervention. Directors and providers have differing perspectives on the availability of resources to support the implementation of strategy training in their facilities, and again, these differences are of greater concern to the providers. We are still disentangling the data on individual characteristics, but so far we have determined that directors and providers have helpful thoughts about what patients may benefit more or less from strategy training. And these thoughts align with the findings from our previous trials. As for providers, the most pressing issue seems to be variations in staffing, once more suggesting that strategies may need to vary based on facility size. While we are working to organize and simply present the data that we've collected from these director and provider stakeholders, it's clear that the exercise that we undertook together has revealed a very rich source of information to inform our next steps. We are hopeful that this 12 months of data collection will elevate the rigor, efficiency, and success of our pragmatic trials in this setting and minimize the occurrence of failed implementation strategies. The focus group interviews also provided useful insights as to perceived barriers to strategy training implementation. We mapped these barriers onto consensus-derived implementation strategies using the CFER Expert Recommendations for Implementing Change, or the CFER-ERIC matching tool. The table on the slide provides an overview of the top 8 prioritized implementation strategies recommended by the CFER-ERIC tool, split out by directors and providers from small, medium, and large facilities. You will note a fair amount of consistency in strategies, including building a coalition, capturing and sharing local knowledge, identifying and preparing champions. There are also distinct strategies, such as conducting cyclic small tests of change. Once we are done with these analyses, we will organize and define these strategies and engage our stakeholder advisory group in the selection and planning of implementation strategies that we will explore in our next hybrid pragmatic trial. To summarize, we set out to conduct a study to characterize variations in context and readiness among rehabilitation facilities, providers, and clientele. And though we are currently in the final stages of data analysis, we are working on the integration of data collected from both aims and the interpretation of these findings to inform our next steps. These next steps will be to engage our stakeholder advisory group to review and discuss the joint display of aggregated quantitative and qualitative themes, as well as our inferences, and also to discuss the facility level variances in outer and inner setting and individual provider and patient characteristics, as well as the recommended implementation strategies stratified by facility characteristics if needed. From this discussion, we will seek advice from our stakeholder advisory group to select core strategies for the implementation in the hybrid pragmatic trial. I will end by returning to the main points. Stakeholders from various perspectives and health system partners are essential to conducting meaningful and successful trials in pragmatic settings. In addition, prospective examination of stakeholder and health system perspectives is useful for elaborating facility and provider context and readiness, informing the selection of implementation strategies, and saving time and money to prospectively plan successful pragmatic trials. As Lane Fall and others suggest, it's never too soon to begin thinking about how an intervention may be implemented. And for that reason, I would argue that if you're conducting trials in pragmatic settings, it's never too soon to engage health systems and stakeholders in intervention and trial design, as well as the conduct of these studies. At each stage of intervention testing, we have engaged stakeholders in the conceptualization and design of strategy training, the pilot testing and later efficacy of strategy training, and in our current planning for effectiveness and implementation testing. Stakeholders in our studies have included current and former patients from inpatient rehabilitation and their family members, occupational, physical, and speech therapy providers, physicians, nurses, psychologists, and administrators, and representatives of the health system and health payer leadership. These stakeholders are essential to ensuring that the interventions that we design and test are amenable to implementation in these settings. I'd like to end by thanking the multiple health system and funding partners who have supported the work that I've presented today. In particular, I'd like to thank the UPMC Rehabilitation Institute, our partner in the early phases of our work on strategy training. And I would like to thank Encompass Health, our current partner in the design of pragmatic trials focused on the effectiveness and implementation of strategy training in inpatient rehabilitation facilities across the nation. These two health systems have provided access to patients, providers, directors, administrators, and health system leaders too numerous to name, who continue to be actively engaging in and shaping the work that we've described today. Both organizations have provided funding support, as well as the University of Pittsburgh, the NIH, the American Heart Association, NSF, and LeaRRn. We are also thankful for funding support from the Australian, Canadian, and Taiwan governments. Before I take questions, I need to acknowledge at least some of the people who've contributed significantly to the work that I've shared. These are research staff members, collaborators, postdoctoral and doctoral trainees, along with dozens of rehabilitation providers and clinical students that have been critical members of our team. And now I'll be happy to take your questions.